Good morning. Today is January 30, 2024. The time is little after 10:30. The Insurance Committee of the Tennessee House of Representatives of the 113th General Assembly is now in session. Clerk, please call the roll.
Representatives Sapicki, Davis, Freeman, Helton Haynes, Hemmer, Hicks of Hawkins, Hill, Johnson of Montgomery, Johnson of Knox, Lafferty, Mitchell, Ritchie, Rudd, Rudder, Sparks, Terry, Thompson, Vice Chairman Martin of Carroll, Chairman Kumar. Mr.
Here.
Chairman, you have a quorum.
Thank you. Members, do we have any personal orders? I take the privilege first of introducing our intern with a famous name, Miss Jayla Fitzgerald. Also, we have an old member who is now the newest member of our committee, Representative Timothy Hill. Welcome. And in the audience, I do see Senator Jim Tracy. Welcome. Members, please be careful. Senator Tracy can be very critical of our performance. On the calendar today, we have one bill, House Bill 916, and I'm advised that the bill is rolled 2 weeks without objection. So we'll talk about it in 2 more weeks. On our calendar also today, we have 2 presentations. The first one is brought to us compliments of Representative Caleb Hemmer. Representative Hemmer, you're recognized.
Thank you so much, Mr. Chairman. I began getting interested in PACE after seeing an article about it a few years ago and learning more about it, and then came to find out that we actually have a PACE facility here in Tennessee that we've been doing in Chattanooga for the last 30 years, predates TennCare. So I had the opportunity to go down with some members this summer and do a tour of the facility and was just really blown away. It's a really interesting program that you would want to be in or you'd want to send your loved one into if you were elderly. And so looking really forward to hearing more about it from the PACE Association as well as TennCare. And hopefully this is something we can bring back to the committee this year and look to see how we can expand this across the state. Thank you.
Well, thank you. We are ready for the presentations. We'll go out of session. The first presentation is the PACE group. And Mr. Sean Bloom is our presenter. Kindly introduce yourself for the record and turn the mic on till you get a red light. And thank you for coming.
Thank you, Mr. Chairman and members of the committee. Thank you for the opportunity to testify today. I'm Sean Bloom, CEO of the National PACE Association. We are a national trade association that represents all operational PACE programs around the country, of which there are 155 in 31 states. What I'd like to do today, if possible, and I want to make sure I have time to address all your questions, is to provide you a brief overview of the PACE model of care, talk a little bit about our growth nationally, the characteristics of PACE, and some of the benefits, both in terms of outcomes as well as cost. So, next slide, please. So the best way to think about PACE is we are actually a provider of care that assumes full financial risk like an insurance company, but we directly employ all of our staff. So the best way to think about PACE, we're community-based. Most of all the programs around the country are based in the communities they serve. They're all centered around a day center model within which the interdisciplinary team does its work. We're comprehensive. What makes PACE very unique is we accept full financial risk for all Medicare and Medicaid services, and the payments do not change based on the utilization or needs of the individuals. That comes in the form of capitated payments, so that's like fixed payment. We don't bill for every service we provide. We get a monthly set fee, and within that, we assume full financial risk. And then lastly, we are highly coordinated because the interdisciplinary team are employed individuals who are salaried. These are individuals that do not get billed or do not get paid based on volume. These are individuals that are direct employees. Should I turn my own slides? Okay. So a good picture of PACE is really, this is kind of the IDT. In the middle is the individual. Each team serves about 150 to 200 people. They meet every day. It's called the morning meeting. And they go through a process of assessment, care planning, and then they just repeat that cycle and really see how the individual does. And we are on the hook for everything financially. So if a person needs permanent placement in a nursing home, we got to pay for it. If they need a hospital care, we have to pay for it. Our payments do not change based on those service patterns. We also, if you can see here, that the interdisciplinary team is really comprised of physicians, nurses, social workers, PT, OT. But what's most important, I think, to see in this slide is that the capitated payment gives us enormous flexibility to get really creative in how we use the resources to keep people at home and out of the nursing home and out of the hospital. So, okay, thank you. So right now, roughly about 100% of people we serve around the country are Medicaid eligible. Of those, about 90%, 87% are also eligible for Medicare, so they're referred to as the dually eligible. To be eligible for PACE, you got to be nursing home level of care, so that's equivalent to you have to be eligible for either options 1 or choices 1 or choices 2. You have to live within the PACE service area. And I don't know if any of you went to the Chattanooga site, but the service area is a pretty simple definition. It's typically a PACE center within which there's a medical clinic, kind of a day center, place for recreation, therapy, personal care, those type of things. And it's a driving radius about 30 to 45 minutes around the PACE center. And it's simple logic. You do not want to keep a frail older adult on a bus more than 30 to 45 minutes. But they also, these are individuals that have a choice of enrolling in PACE, about, as I mentioned, there are about 70,000 people around the country. Who do we, so 95% of our folks live in the community. Stated differently, throughout the country, on any given day, on average, only about 5% of our people permanently reside in a nursing home. That figure is a little bit different from state to state, in particular in Tennessee. And a lot of that has to do with the availability of local services in the area. The average age of PACE is 77 years of age. Much like this older cohort, about 2/3 are women, 1/3 are men. Very, very impaired population, and about half of our enrollees have some diagnosis of dementia. So this is a very, very frail population. As you can see, then these are the top diagnoses for our population. They take 6 prescription drugs on average. We are a Medicare Part D provider, so when they enroll in PACE, they get all their Medicare, all their Medicaid, their prescription drug coverage. That's all included in their service package. On average, we bring people to PACE Center about 5 days a month. That used to be about 10 prior to the pandemic, but we are still slowly kind of reutilizing the day center, having pushed all the care into individuals' home during the pandemic. And we've got about 5.8 chronic conditions on average for each participant. This is just kind of an example of some of the day-to-day services that are provided. You know, I mentioned that with the capitated payment we receive, we have an enormous amount of flexibility. We build ramps, we can buy air conditioners for the window, buy microwaves, we can get them a cell phone, we can do modifications to the home. We've, on occasions, had individuals that have chosen PACE who've been in and out of the hospital simply because they had a flea-ridden environment, 2 or 3 dogs. We could come in and flea dip the dog, rip out the carpet, kind of clean the house up, and avoid a lot of downstream utilization of emergency room and unnecessary hospital care. But it's important to note, if an individual needs additional services, we have to pay for them. We don't bump them up into a higher payment category under Medicaid if they need nursing home care. Today, we've got about 155 organizations around the country. The reason we express the number of PACE centers differently is some of our rural programs in particular serve a very large geographic area, and they may have multiple centers in their area. Right now, 32 states, District of Columbia, have PACE organizations. We have been working for over 20 years to support the growth of PACE, and we're about 155, but we are looking at enormous growth moving forward. We're looking at about 50 to 60 new programs over the next 24 months. So As Representative mentioned, we do have a PACE program in Chattanooga. It's what was one of the original, what I call post-demonstration PACE programs in the country. It's been operated by Alexian Brothers, which is now part of Ascension, a large Catholic health system. They serve about 300 people, and that really only represents about 6% of the population within the service area. So I want to do a little bit of kind of analysis of rate comparison. I know there's two parts to choices. Choices one, which is really the nursing home kind of service component. And then choices two, which is the HCBS, or think home care and other community-based services. I think it's been identified that about 50-50, the split of people where they're served is about 50-50. That leads to total cost of about $54.28 per month. Our rate is $50.84 per month, but it's not going to change if an individual needs nursing home care. So if you look at that, you know, our costs on their face are about $340 less per month. And on a national average, that's about on an annual basis, that's about $41.33 less. It's also important to note that, again, as I mentioned, once you establish a rate for PACE, in the case of PACE 5084, that will not change through the year. So I do a lot of work in the states, and I think one thing that the budget folks and the legislatures really like is the fact that you can identify how many people you want to serve by PACE. You can multiply it times the monthly capitation, and it is entirely budget predictable. The costs are not going to change based on utilization patterns because it's fixed. We're at full risk. So that's something that's quite attractive. In Tennessee, about 14% of the people are in nursing homes, and I'll talk about that figure here in a minute. And it's important to note, kind of as a basis of comparison as well, that represents about 35 people served by Alexian Brothers in Chattanooga that are in nursing homes. That costs the program about $118,000 a month. If you were to roll them into choices, that would be $267,000 a month. That's a big difference, but that's risk that we assume that motivates us to keep them out of the nursing home. So did a little analysis also, like what would cost look like if you were to add a program? You know, our national rate of growth monthly is about 7 or 8 people. So really what we're talking about, if you added a new program, you're looking at less than 100 people in a year. Now, you could certainly amplify that rate of growth, but that's kind of a national average. So you'd have about 85 participants. But if you go back and look at the monthly cost savings, $41.33, you multiply it times 85, you're looking at very significant cost savings just for a mere 85 people. This is just a case study. You can find this on our website. We did this 2 or 3 years ago. It's an individual. We do target individuals in nursing homes that are suitable to move back in the community. This is a video. You can literally go to our website and watch her testimony. But she had multiple strokes, 2016, couldn't walk, required nursing home care. She was in a nursing home, and in May 16, we brought her into PACE, and she was able to achieve her goals and moving back home and walking by the end of the year. She's still enrolled in PACE, and it's a testament of the good work that we can do with the full team, focusing every day on the needs of those individuals. We have been studied to death. There's a lot of evidence on the outcomes of PACE. There was a recent HHS federal study that found that we are a consistently high performer compared to other service options. In terms of just what you can experience as an individual served by PACE, our folks use less than 1 emergency room visit per year. That's very low for this population. Our folks use on average less than 3 hospital days a year. All these kind of statistics really demonstrate how intense these individuals are coordinated and managed by the team. As I mentioned, average nursing home placement nationally is only 5%. So we have a 95% success rate keeping people in the home. And we're obviously invested really proactively in identifying individuals' needs, which may lead to unnecessary hospitalizations in nursing homes. And then we do an annual satisfaction survey, and we get a lot of press on this. And we also not only survey the individuals we serve, half of whom have dementia, but we also survey their families, and we find that 97.5% of people consistently from year to year would recommend PACE. Low disenrollment rates, high satisfaction, good outcomes. I'd be happy to answer any questions.
Well, thank you. You kept it reasonably short and concise. Um, just a few questions that come to mind. What is the difference between PACE program and the usual Medicare Advantage plans?
Medicare Advantage plans they're a health plan, they're an insurance company, so they are not typically direct providers of care. They just assume risk. In the case of Medicare Advantage, it's only Medicare risk. Secondly, any Medicare beneficiary is eligible to enroll in PACE or in Medicare Advantage, whereas in PACE, you have to be nursing home eligible. And the other difference in PACE and Medicare Advantage, we are operating with both Medicaid risk and Medicare risk. So I would say it's three things. One, we're a provider, not a health plan. Two, we're managing not only just Medicare risk, but Medicaid. And three, we exclusively serve a nursing home eligible population.
And you mentioned that majority of those people do live within the community. They are not confined to the nursing home.
Correct.
And what is your funding mechanism? How much of your funding comes from Medicare? How much from Medicaid?
It's about 60% from Medicaid and about 40% from Medicare.
Okay. So the 40% that comes from Medicare, is that comparable to what the Advantage plans get?
Yeah, you're asking a question. I'll try to give a simple answer. The way the payments are set for Medicare Advantage and PACE, it's based on an individual's diagnoses. It's called risk adjusted.
Okay.
And what comes out of the calculation is a number. In the case of PACE, our risk score is 2.6. Really what that means is we're 2.6 times more frail or sick with disease than the average Medicare beneficiary. So you just multiply that 2.6 times the average payment under Medicare for Medicare beneficiaries at the county level. Hopefully that makes sense.
Go ahead.
I said, I hope that makes sense. It's a little technical. So
Well, no, thank you. It's interesting that you're able to take a population that is eligible for nursing home and keep them in the community. How do you manage that? What is the secret?
really, really good in my opinion, very good primary care up front, very comprehensive assessment, multidisciplinary assessment. So when an individual enrolls, social work is doing an assessment, nurse, physician, PT, OT, dietitian, and they will literally assess the needs of the individual and put together an integrated care plan and monitor that person very closely on a daily basis.
And drug benefits are included in
Yep.
the care. And I assume you would have some chronic disease monitoring where a nursing staff or somebody checks on patients with chronic illnesses.
Yeah, we have, again, I think you're a clinician. We have a whole toolkit of model clinical practices that really follow the individual's goals of care.
Okay.
Meaning that we're not doing intense, invasive preventative care on someone with 3 months of life left. These are clinical protocols that we've established and really fine-tuned over the last 20 years.
Well, thank you. Thank you. It's been very interesting. A lot of us were not aware of the program, and it's opened our eyes. I'm grateful to Representative Hammer for doing that. Representative Thompson, you're recognized.
Okay, thank you, Mr. Chairman. Just have some organizational questions. I mean, as far as, do you actually own and operate nursing facilities, or do you contract with others, or?
That's
that
a really
work?
good question, and I always regret not clarifying that up front. I would say 95% of our programs are sponsored by larger health systems. So many of them already have nursing homes, like Alexian Brothers. They've got Alexian Brothers Village on the mountain, Signal Mountain. So the three things that PACE programs almost universally contract out for are hospital acute care services, medical specialist, and nursing homes. Everything else is provided directly. So the short answer is yes, we contract out for nursing homes, but in some cases, the person that owns PACE, Johns Hopkins, whatever the case may be, has a nursing home that we contract with, but it's at the sponsorship level.
You're recognized.
Okay, thank you, Mr. Chairman. As far as providers, do you employ providers, or do you contract with them, or a little bit of both, or how does that work?
Yeah, the best thing to do, if I can go back to this slide.
Forgive me if I missed something.
No, I went through a lot really fast. This really is the team of employees. We call them the IDT, or interdisciplinary team. These are directly employed individuals. That's all they do. So they're salaried employees, and they meet every day. It's called the morning meeting, and they talk about the care needs of the people that they're responsible for caring for. It's very simple, but it's very intense and very continuous.
Okay.
You're recognized.
Thank you. So what have been some of the, I mean, of course, their turnover rate is terrible among providers, especially, well, nurses and some of the lesser skilled staff too. Have you had major problems with this? Can you sort of give us an idea of that?
Yeah. I'm from Kansas. My family operates rural nonprofit nursing homes, so I'm aware of this. And I used to be a nurse aide when I was in high school. There's a lot of turnover in nursing homes in particular, not just frontline staff, but nurses. We have not experienced the same degree of turnover. As you can imagine, a home care aide sitting at the table with a physician talking about the care needs of someone is very empowering. And all the people that work in PACE are very important eyes and ears to what's happening, and their voices are very much valued. So you see a lot of people that really move in and work in PACE and generally stay there. That's not to say we haven't had some labor shortages, but in terms of the turnover of staff, it's relatively low. Because if you can go see the model, you'll see you can really get a lot of enjoyment out of it and a lot of satisfaction as a caregiver.
Okay, thank you.
Another question comes to mind. So the members that you have, they have to be Medicare and Medicaid eligible.
Well, actually, technically, they don't have to be Medicare eligible. They don't have to be Medicaid eligible. We do have a very small number of people that are only eligible for Medicare, and they pay out of pocket the equivalent of the Medicaid payment. And they do that because we're about half the price of a nursing home, and they can stay at home.
Thank
So-
you. Representative Hemmer, you're recognized.
Thank you, Mr. Chairman. When I think about, just kind of put some color on it for the members of who would be benefiting from this. I've got a next door neighbor who is an old retired physician. His name's Doc, and he provides me with good company and bad jokes. But he is, an ideal candidate for this because he lives at home, sometimes a wheelchair, mostly in a walker. Daughter lives with him to take care of him, but she goes to work during the day. And what we've seen, especially post-COVID, is seen this epidemic of loneliness. And you see the model care in this system and essentially the services that provide is what struck me mostly, because when we compare it to a Choices to HCBS model, there are a lot more services and it's a lot more wraparound services. For instance, this driver that picks up this member, you hear all these anecdotal stories of, hey, something's up with this guy. I pick him up every day. I pick him up weekly. I know something's wrong. And they're catching these things that would have not happened otherwise, and they're able to get that social component. So one thing I wanted to, if you would go back to the slide around the services, maybe talk to how your model care with PACE and the additional services provided are much different and actually go much further than a Choices model.
Yeah, this is an opinion, not a fact, but I do believe that really to mitigate or reduce the risk of nursing home placement and hospital care, you really have to coordinate and integrate primary care. So the notion that a physician is really looking at medications, looking at fall risks, if they got medication that's causing delirium and dizziness and dehydration, that's a fall risk, which is typically the gateway to get into a nursing home. So it is really important to acknowledge the reason we are able to achieve the outcomes we are, because we don't really look at just Medicaid, Medicare. They don't even look at a budget. They just provide the care that makes sense. So good care and PACE equates to good outcomes across the board.
And just one clarification, if you could, that the MCO is not involved with the PACE. And then also, example, what happens if someone goes to the hospital nursing home after being in PACE? And I'm talk through how the PACE assumes that risk.
We have to have contracts with hospitals and nursing homes, and if they are permanently, if there are people I know that have been in nursing homes 3+ years they're just either very advanced late-stage dementia with significant elopement risks or other conditions. We got to pay it. It's on us. As far as hospital care, I know of a case that I'm working on right now where this individual was in ICU for 90 days. It's about a $900,000 claim. Medicare's not going to pay any more. Medicaid's not going to pay any more. It's on the PACE program. So, no, the risk exposure is limited just to the PACE program.
Well, thank you. Members, any questions? Representative Lafferty, you're recognized.
Sorry, I forgot the process there. Thank you, Mr. Chairman. You mentioned the three things that contract out. You said nursing home specialist, and what was the third one?
Hospital care,
Thank you very much. Thank you, Chairman.
certainly.
Representative Sparks, you're recognized.
You know, I just want to tell you, I appreciate it. I've got a sister in a nursing home, been there 5 years. Many of us have had to care for our parents. I know Representative Rudd took care of his mom for many years, took care of my mom for 5-6 years. You know, they called in hospice on my sister. So anybody who's had to feed somebody or care for them know how critical this is. And what worries me, I don't know if former Senator Jim Tracy is still in the audience, but I think we're on a cliff if we're not careful with caregivers in the next 4 to 5 years. And when you start getting a little older, we need to start getting concerned about this. So thank you, Representative Hammer, for inviting PACE, and thank you for your testimony, sir.
Thank you very much. I appreciate it.
Any other questions? Well, Representative Ritchie, you're recognized.
Thank you, Chairman. Thank you for coming in and sharing this awesome services and everything that you're in providing there. Definitely needed. The one thing that just kept popping into my head was when you're on the slide saying that the current service range is about 6% of the estimated eligible. Is there from a community awareness disconnect of knowing that the services are there? Or is there something that would end up being able to make sure that more folks are aware that this is available there in the Chattanooga area, so to speak?
Yeah, I'm glad you asked the question, because in the time allotted, I skipped by some stuff pretty quick. And that's meant to be market penetration rate. So if you look at it in the case of Chattanooga, their market area, I don't have the zip codes around me, they're only serving 6% of the people that are theoretically eligible for PACE. The obstacles to higher market penetration are awareness. Like when people need care, if you have a relative needs care, you go in and get them assessed, and you have information referral. That could be one obstacle. In the case of Tennessee, it's also, I believe, the case that the enrollment is capped in the budget. So they're only able to serve, I think their cap is 300 people. I'd have to check on that. But I do believe that their enrollment is fixed by virtue of the annual budget that's allotted.
Well, considering that you're providing a good service, you're saving money, and how long has the PACE program in operation?
Yeah, we started as a demonstration program in the late 70s, early 80s, and then it was replicated, much like hospice, and said, does this thing work? 13 programs were set up, studied extensively, and then the Balanced Budget Act of 1997, PACE became a permanent Medicare benefit, and then this next term is important, an optional Medicaid service. So we exist at the pleasure of the states in terms of whether we exist and to what extent PACE is available throughout the state. So we've been around 25 years.
In your opinion, the program is scalable to a statewide level?
Yeah, we have several states that, there's almost universal statewide access to PACE. Pennsylvania, Ohio just allocated. They're going to be pretty close to statewide pretty soon. They allocated 7 new markets just about 6 months ago. I could go on and on.
Are those programs operated by PACE or similar entities?
They some are operated by some. Are you talking about Ohio, or in general?
Any other programs?
Yeah. Well, 90% of people that operate PACE are existing healthcare providers. So the type of organizations that set up PACE are hospices, health clinics, hospitals, long-term care groups like Alexian and Chattanooga. That's what their roots were. They were serving older adults in the community. You know, we've got one health plan in Western Massachusetts that operates PACE, but it's primarily healthcare organizations that have some experience serving a elderly population.
Well, thank you for the discussion and explanation. Seeing no further questions, we are grateful for your information.
I appreciate the
Thank you for
opportunity very
coming.
much. Thank you.
Members, if we still have your attention, we move on to our second presentation, and that is about choices. Who do we have? This side. We have Mr. Zane Seals and Ms. Katie Evans. Thank you for coming. Kindly introduce yourself for the record and make sure your mic is on with the red light.
Thank you, Chairman Kumar. Thank you for having us today. I'm Katie Evans. I'm the Chief of Long-Term Services and Supports for the Division of TennCare. And we're here today to share some information about the Choices Program. The Choices Program was created by this legislature in 2008 through the Long-Term Care Community Choices Act. And in approximately 2012, this was implemented statewide. Choices is a program where we integrated long-term care into our managed care programs, making it fully capitated. Our managed care partners are fully at risk for each member in our Choices program for folks who receive nursing facility care or home and community-based services. And this program specifically is aimed at individuals who are over 65 or who have a physical disability and are over the age of 21. The goal is to keep folks in the community as long as possible if that is their choice. Before implementation of the Choices Program, back in 2008, about 97% of our population in the state who needed long-term care went to a nursing facility to receive that. Today, in 2024, we're about 60% are receiving care in the community, and about 40% are in nursing facilities. And this is a crucial program. It has really changed the trajectory of our state. This program was implemented by my predecessor, Patty Killingsworth, who is known nationwide and has put Tennessee on the map as a leader in long-term services and supports. Multiple states look to us for guidance and support in how to best serve their older adults and people with disabilities in their states, and look at our model for implementation. And I will say, when we look at the PACE model, a lot of what we do in Choices is modeled after that. The goal is holistic services. The goal is focusing on the whole person, having the person at the center of every decision that is made, at the point of making all of the choices. And our managed care organizations assign a care coordinator for each individual who is enrolled in the Choices program. So they each have one person who is responsible for coordinating their care, assisting them with choosing services, and working through any issues that they have as far as community needs, natural supports, those sorts of things. And so some examples of the services available in the Choices program overlap with PACE. However, the Choices program does offer additional services, including home modifications, group home residential services. So that looks like kind of an adult care home, where an individual can live with other adults with similar disabilities, or could be a family model community living placement where it's essentially like an adult foster home where a family takes in someone who's not related to them to support and provide their care. We also offer what's called companion care services, pest control, personal emergency response services, an additional cafeteria plan of services for the individual to choose from. And all of this is with the goal of keeping the individual in the community as long as possible if that is where they choose to reside. Our care coordinators in the program are employed by our managed care organizations. They are responsible for ensuring that the individual has all of their services coordinated, make sure they get the right health care, not just long-term care, but the right health care, follow up with them on hospitalizations, ensure that there are discharge plans when they're put into a hospitalization or have to go to the emergency room. They are responsible for ensuring there are social services to keep the individual integrated in the community. Really, really key component of all of our home and community-based services is not just keeping the person in their house, but truly integrating them in the community, having other individuals that they can interact with, volunteering, em- being employed if they so choose. We're actually really excited. We'll be rolling out employment services in our Choices program as soon as CMS approves that pending amendment. And we're really excited to see this opportunity for our older adult population and our individuals with physical disabilities. We also require the care coordinators to ensure that natural supports are wrapped around this individual to ensure that they have all the services they need to remain in the community, as well as services that are reimbursable through other sources like private pay and Medicare. Really important to us in all of this is ensuring that our members are receiving the care that they need and that our managed care organizations are complying with all of the requirements. So we have several quality measures that we look at. We ensure compliance through the use of National Core Indicators, Aging and Disability annual surveys, or the NCIAD. We also look at our network access scores to ensure that there are providers that are locally close by to the member who needs care. We look at individual member record reviews where our team pulls a sample of the person-centered support plans to make sure that the individual is getting the services that they want and need and that services are initiated timely. We also do this for our new members that are enrolled. And we also look at ongoing reporting related to service initiation delays and challenges in workforce. In the most recent NCIAD survey, 80% of our Choices members indicate that they have all the services they need. This is higher than the national average of 69%. And then 89% of those surveyed in this in the NCIAD reported that the services that they receive help them to live the life we want, which is what we all want. We all want to live where we want, have the services, have our needs met in the location where we choose to live. One of the key components of everything we do is continuous improvement. We recognize that there is a population subset within our Choices program. It's actually most of the population that is dually eligible for Medicare and Medicaid. And we all know Medicare and Medicaid are both complex programs, complex federal regulations, lots of rules, lots of requirements. And one of the things that we have been doing for years is working to improve that care to our dual eligibles. And one of the ways we do that is through our dual special needs plans. Each of our managed care organizations is required to have a dual special needs plan that supports members who are Medicare and Medicaid eligible. Now, taking that a step further, they also are required to have what's called a fully integrated dual eligible special needs plan. And that is for individuals who are enrolled in the Choices program who have Medicare and Medicaid. And it's an additional layer of coordination of care and services and that alignment between Medicare and Medicaid services, ensuring that Medicaid is the payer of last resort, that the individual is getting the services they need across the continuum as their needs change. And one of the things that we are really excited about is that we are partnering with a nonprofit to improve the coordination of care for this subset of the population and ultimately hoping to implement some cost shifting opportunities to save state funds by shifting some of these costs to Medicare from Medicaid. And I'm going to turn it over now to Zane Seals, our Chief Financial Officer.
Good morning, Chairman and members of the committee. My name is Zane Sills, and I have the privilege of serving as the Chief Financial Officer for the Division of TennCare. I'm going to take just a brief moment to discuss some cost comparisons between Choices and PACE. I think there's been some questions over the past few weeks and maybe a little bit of confusion around how the cost of our Choices program compares to PACE. In order to analyze that question and that cost comparison, it's really important important to do that accurately, that we use the correct comparison population. And for this, it really is our Choices 2 population, the Choices 2 population that, and the PACE population that are the directly comparable apples to apples populations. Both populations are nursing facility eligible. Both populations offer a similar range of services. Both populations are fully capitated at-risk capitation rates, as has been discussed today. I think it's probably true in a lot of other states, or not probably true, it is true in other states that don't have a choices program like Tennessee has, that in the absence of a PACE program, Medicaid recipients would just wind up in nursing facilities because there's not any other option. But in Tennessee, we're unique in that we have the Choices 2 program. And so there is an option for people that they may qualify for nursing facility care, but they want to be served in the community. There is an option for them to be served in the community, as Katie just described in the Choices 2 program. So that really is the comparable population. If we look at this slide as a couple of different rates, just to illustrate what the most up-to-date rates are for all of these programs that we as a Medicaid program pay. These are using East Region rates. We picked the East Region because that's the only region we have a PACE program in currently in Hamilton County. And you'll see that Choices 2, which is the actual apples to apples population, is significantly less costly than the PACE monthly PACE rates we pay. Both are less costly than nursing facility care, but Choices 2 is even more on the low end. It's important to note again that all the rates you see up here are all fully at risk. So, no matter what the utilization is, either the PACE program or the MCO gets that set fee on a monthly basis, and that's what they have to use to pay for the care, whether it's home and community-based services or if somebody gets sent to a hospital or whatever, they still have to use that monthly fee to pay for that. So just wanted to kind of go through that cost comparison really quickly. Hopefully that's helpful for you. And then just in closing, before we turn it back over to you for questions, we also wanted to make it really clear that we do value our partnership with the PACE program here in Tennessee. They're a wonderful program. They do a great job serving our enrollees in Hamilton County. It's just important that as we look at different policy options and evaluate those from our perspective, that we're using the correct data points to show those cost comparisons. Thank you.
Thank you. Thank you, members. Do you have any questions? I will think of a couple of things for you to enlighten us. What is the essential difference between Choice 1 and Choices 2 program?
The Choices 1 program is for individuals who choose to receive care in a nursing facility. The Choices Group 2 program is for individuals who choose to receive care in the community. Same requirements. You still have to meet the nursing facility level of care requirements, just like PACE.
Okay. And funding sources for these programs are basically Medicare and Medicaid?
Sorry, turn that off there. Yes, sir. Medicare, Medicaid. I think there's private pay as well in the mix. For our part, the Medicaid program, we do pay for Choices 1, Choices 2, and PACE, and those all use the exact same match rate. We have a federal match rate of about 35, 65 state dollars to federal dollars. It's the same match rate for all those services.
And the Choices program is operated by TennCare.
Yes, sir.
What is the total enrollment at this time?
In the Choices Group 1 program, we're somewhere around 12,000 members. In Choices Group 2, we have around 9,000 members. And in Choices Group 3, which is a subpopulation, we have about 3,000 members. The folks in Choices Group 3 don't have to meet nursing facility level of care. They're just at risk for nursing facility level of care. And then we have about 300 folks in the PACE program who have to meet the same criteria as Group 1 and Group 2.
Very well. Thank you. Representative Davis, you're recognized. You're a little rusty.
Thank you, Mr. Chairman. I was trying to remember my name too, so no worries. But just in kind of looking at the PowerPoints in front of me, it does say that PACE services people 55 and older, and that the Choices Program is eligible adults over 65 or adults with physical disabilities over 21, right? So I just want to make sure that the population age is also a distinction as well, correct?
There is that slight distinction, yes, Representative Davis, the 10 years. However, we do serve individuals, like you stated, over 21 who have a physical disability.
You recognize? Oh. Representative Davis, did you have any other questions? No. Okay, all right. Does anybody else have any questions? Seeing none, thank you for coming. We'll go back into the session. Members, any other business to bring before committee? Otherwise, motion to adjourn? We stand adjourned. Thank you for coming. We'll do it again next week. All right. Thank you. No problem.